We'll give Chair Ferreira another minute here, right with everyone. There's Enrique.
Oh, hi, everybody. Sorry, those letters, you know.
No worries.
Awesome. Happy to wait another minute or so if you want, Ali.
Yeah, I think we're actually good to go. I think got a quorum. Okay. I think we're all right.
Awesome. Thank you. So happy to call the meeting to order at 1:03. Thank you, everybody. And all of you received the materials and the agenda via email. So I need a motion to adopt the agenda with flexibility for today's meeting, March 3rd.
I move that we adopt the agenda as printed with flexibility.
Thank you, Rick.
I'll second.
Thank you, Bill. All those in favor to adopt the agenda with flexibility, raise your emoji or your hand or say aye.
Aye.
1, 2, 3, 4, 5, 6. I see you, Robert. Thank you. All right, motion carries. Thank you. Thank you, Sally. I see that. And now I'm going to hand this off to let me do a roll call really quick of our board members. And then I see Bill is here.
Here.
Robert.
Here.
Some. Susan. All right. Sally.
Here.
If I hear you. And then we have Rick. Can I start Rick?
Present.
Awesome, Rick. And then we have Susan Miller. Okay. Dr. Lara, Andrea.
Present.
Thank you. Bonnie. Okay. Tony. Cheryl. Is Cheryl here yet? All right. I think we're missing 3 folks. Ali, is that correct?
Yeah, I think you might have an old.
Yeah, I didn't hear my name.
Yeah.
Who is that? I'm sorry.
Michelle Dewberry.
Oh, sorry, Michelle. Go ahead. Yep. All right, got you, Michelle.
Yeah, I do think we're missing 3. That's correct.
Yeah. All right. Thank you, Michelle. All right. So still carried. So I'll hand the next part of the agenda. It's Ali.
Yeah, thank you. Well, welcome everyone. I'm so glad you could join us today. I just wanted to, before Mercer begins walking through the 2026 renewal update, I wanted to take a moment to kind of level set a bit as we begin this renewal process. As I mentioned in my message to you on Friday, the composite rate starting point of over 13% is the highest round 1 starting point that we've had in several years, which I know is alarming on its face. And but please do remember the OEBB board, since its inception in 2008, has pulled through challenges as great, if not greater than this. You know, the OEBB board does maintain resources, tools available to you, and and we'll have some options so you can really take this challenge head on. I think today Mercer and our insurance carrier partners will dive into what's driving this trend and give you the opportunity to ask any questions that you might have. You'll also hear about what is being done and what can be done to address the upward trajectory of this healthcare trend across the state and what we see around the country. You'll hear a lot about that from Mercer. Also, coordination with our OEBB advisory committee is in full swing as our legislative concepts targeting the 3.4% statutory relief and other cost saving measures continue moving forward in anticipation of the 2027 legislative session. This coordination with our advisory committee will be key in helping the board make informed decisions for not just this renewal, but really looking beyond this year and developing a strategy for future renewals focused on protecting current plan designs. So next month will be the meeting where the board starts considering various approaches to get to a 3.4% composite rate renewal by the May meeting. We have all been working since the start of the year, even before that, to develop reasonable approaches to this problem. Please do know that we as staff, Mercer, the advisory committee, and even the carriers are here to support you through this process. And we can definitely set up one-on-one meetings if you have questions or need additional information on anything. I'll continue to make that offer to you, so please feel free to reach out for any assistance that you have. With that, if there's any questions, I'll go ahead and hand it over to Mercer to begin their presentation. Thank you.
All right. So before we go to the next part, I want to make sure we review the minutes of our previous meeting.
Yeah.
Are there any
Thanks.
corrections to be submitted? All right, without objection to adopt the minutes after presented, all those in favor say aye. Or raise your hand, or Emoji. Robert, Bill, Michelle, Sally, all right, awesome. Greg. Thank you. All right, motion carries. So we have adopted the minutes. Thank you, Ali, and thank you, everybody. All right, our next presenters, please feel free to start.
Thanks, Enrique. Thanks, Ali, also for starting us off. Good afternoon, members of the OEBB board. Rose, if you would advance forward to the agenda. Thank you so much. Let's just spend a minute here, all regrouping and thinking about what we're going to talk about and put our heads together on this afternoon. So as Ali mentioned, we have a larger renewal than we have had historically. It's not the only time that we have started off above 3.4%. And as Ali mentioned, with his leadership and the support of OHA and also your support, OEBB board, we've been able to achieve 3.4% renewal over the last few years, every year, but more, I just mentioned the last few years because those have been more challenging. It is our priority, and we'll talk about this when we come to the balanced framework at the end, which will ring a bell for many of you. It has always been our priority and will again be our priority to protect benefits as much as possible and have that be our number one priority as we craft a balanced renewal strategy with you. So we're going to kick off the day by just level setting on the renewal. What is the renewal starting place? And we'll look at by carrier and also by line of coverage, renewals as of March 3rd, 2026. And then we'll talk about the natural question that you'll have. You're probably already having it, which is why? How did we get here? Is OEBB normal or an outlier among other groups? Why do we continue to have elevated trend year over year? So those are all the right questions to be asking, and we'll spend a fair amount of time understanding what's been going on in the broader healthcare ecosystem that OEBB is also going through here locally. Kaiser and Moda are then going to come and each speak to how the different factors of trend are specifically impacted by their different delivery models. So we've talked about this before, but Kaiser is an HMO and MODA operates a PPO network of providers. And those two different delivery models impact the timing and some of the other factors of trend. So they'll come and speak to you about that and also talk about some things they're doing to manage trend. We'll come back together with a preview of the renewal strategy. We, as part of our work for you and on behalf of you, we monitor the experience monthly. And so, we were able to start having conversations with your carrier partners and with staff months ago about potential ways to achieve 3.4% while protecting benefits. The details are being worked out. A lot of different ideas are being explored, but we wanted to give you a heads up about the ideas at a 30,000 foot level this month so that when we come back and see you all in person in April with more details, you'll have something to anchor to. And then we'll end on a slightly different, lighter and more positive note with a standard update from John Kessler on where the standard renewals are coming in. I might go a little slower than normal too. I want to make sure that we give you guys opportunity to digest everything that you're seeing and be able to formulate questions and also raise your hand and ask them. So we'll go to the next slide. By the end of today's presentation, we want you, the OEB board, to have a good understanding of the overall starting place for the 26-27 plan year renewal, understand what's going on in the national and local healthcare market that is leading to higher increases, not just for OEB, but for commercial clients across the board. We'll hear directly from Kaiser and MODA about what they're doing to manage trend. We'll preview the 26-27 renewal strategies. We should have worded that a little bit differently. We'll give you a preview of some of the ideas we're working on to bring to you to craft a renewal strategy. Just a quick note on timing. In between when we meet now on March 3rd and the in-person meeting in April 7th and the following meeting in the beginning of May, we will have updated experience. That means we'll have more information about how your care is running, which will help us make a better, more accurate prediction of what we need in premium the following year. Of course, the goal with all of that is to be able to have a lower renewal increase over time. So it's a slightly modified schedule compared to prior years to OEB's benefit, we're hoping. The next board meeting will be on April 7th, 2026, and we are very excited to see you all in person. Those discussions are always very informative as we collaborate and work together to craft the renewal strategy for OEB this year. Any questions on timing? Great, let's go to the next slide, please. This is just a visual illustration of the timeline, working towards a May 5th final decisions date, and then there will be a fast and furious rate process after to get rates posted and distributed to all of the entities who need them. And then, of course, decisions go into effect for OEB on October 1st. It's our plan year. In these initial months of the renewal process, this is in the blue box, in the initial months of the renewal process, we're focusing on this iterative process of evaluate and negotiate. And so we've received renewal proposals from all of your carriers for your various lines of coverage. We'll evaluate what are they offering, how did it compare to last year, how does it compare to what we expected and what we asked for, and then we'll issue follow-up request to the carrier saying we want you to improve on this or provide this additional information. And then that comes back and we go through this cycle effectively 3 times. You're seeing it first on March, although you had a little preview of some dental and vision options last month. But we see the full package of renewal options for the first time this month, and then we'll see it again in April, and finally the final versions in May. Next slide, please. Because it's a slightly different renewal schedule than prior years, this is more of a slide that you can take away with you or refer back to if you're curious about, is there a decision required for coverage? In some cases, the answer is no, because we're in the middle of a multi-year rate guarantee. For most lines of coverage, the decision is yes. The OEB board will need to make a final decision regarding the renewal and what it looks like and what options you want on May 5th. We'll make all the decisions together. So let's go forward, Rose, please, 2 slides to the slide that says Kaiser renewals in historical context. You're going to see this theme echoed many times today throughout the slide deck, which is we are at a little bit of a crossroads in terms of what's been going on with the healthcare market. And so we wanted to put the Kaiser and MOTA renewals in context with renewals in prior years at the same point in the renewal cycle. And what I mean is, so Kaiser, this year, the medical renewal is 3.81%. So already coming in almost at 3.4%. This is a bright spot for the day and a relief compared to prior years. Part of that is timing because Kaiser is an HMO. And so their timing is advanced compared to MOTA's timing. Kaiser will speak to that and potentially MOTA also. The dental renewal is coming in at 4.24% overall, and the vision renewal at a rate hold. So overall blended together, the Kaiser renewal as of March 3rd is 3.81%. Compared to this renewal in prior years, you're going to see this trend, and it's going to be echoed in MOTA as well, which is we have had increasing renewals every year coming out of the pandemic. Each year there have been different reasons for that. Initially coming out of the COVID-19 pandemic, we had pent-up demand from when the provider offices were closed. We had an escalation in chronic care prevalence. We had some claims were suppressed because there were provider appointment shortages. And then when we improved access, there was waiting demand to fill the new appointment slots. And so we had a big push on utilization last year. So it's been one factor really after another that's been driving and to some degree coalescing together and all working together to drive these larger renewals. We're very, very relieved on behalf of OEB members and the OEB board that the Kaiser renewal this year is coming in at 3.81%. We had to make some really difficult decisions last year around the Kaiser plans, and we were really wanting to avoid doing that again this year. And we'll have 2 more iterations of the Kaiser renewal. Let's go forward a slide and look at the same information for MOTA Health. So again, we have 3 lines of coverage with MOTA Health: medical, dental through Delta Dental, and also vision. For MOTA, the 26-27 renewal as of March 3rd is 18.3%. The dental renewal is at 2.92%. The vision is currently calculating a small decrease at minus 0.76%. The overall premium weighted average increase is 16.73% for MOTA. When we compare this renewal as of March 3rd to historical renewals as of the same time period, we see the same pattern that we did with Kaiser, which especially going back to plan year 22-23 has been an escalating increase in the initial renewal position, reflecting various factors going on in the healthcare market. Again, because Kaiser and MOTA are different delivery systems with different factors and timing, it's not as identical, especially earlier on. But the trends of rising increases are similar, and we're going to spend quite a bit of time talking about why 18.3%. Okay, let's advance forward a slide, please. Let's look at the overall total together. When we say that we need to achieve 3.4% overall renewal through our balanced approach, what we mean is that the premium weighted average, so that's the second column, the percent change, all the way down at the bottom, the premium weighted average of all of the medical, dental, vision lines of coverage and carrier combined together, needs to equate to 3.4% overall. So in this graph, this is one of the ways that we track the strategic options that we bring to you to make sure that we can arrange enough options to achieve 3.4% is by measuring the gap. And the gap to 3.4% is in the final column. So you'll see the total gap is about 111 million, which is a little bit more than double a usual amount for us. So we have our work cut out for us. As Ollie mentioned, we are all going to work very hard together and stay calm and get there in a way that serves OEB members, acknowledging that it's a challenge for sure. The $111 million gap, if we go up to the top, the MOTA lines of coverage are listed first, and you'll see that that gap is primarily related to the MOTA medical renewal, which is coming in at 18.3%. And then the Kaiser gap is about 1 million overall. And then Willamette Dental and VSP are contributing about $500,000. And we do want to mention we're working with Willamette Dental. We're working with Willamette Dental to help them understand that in the environment where we're capped to 3.4% increase annually, it doesn't work for the OEB board and its members to have very low increases year over year for many years and then try to get one big true up in a given year. It's just not a practical way to approach the renewal. And so we will bring options next month. But we're actively working with all carriers. I just wanted to mention Willamette Dental as well. So as we go forward throughout the rest of the day and talking about medical trend drivers, and then at the end of the presentation, when we give an overview about the ideas that we're working on, what we're trying to do together is come up with a package of options, including improved experience, that gets us to $110 million overall, while preserving as much as possible the current benefits for OEB members. So that's the goal, just to state it explicitly for everybody. But we've included on the next 3 slides the medical, dental, and vision rating assumptions. I just want to call out, these are mostly for your reference and also for documentation, but I do want to call out a couple things. Similar to prior years, the medical renewal calculations do reflect the trend guarantee penalty. The MOTA credit of 386 ppm is larger than the Kaiser credit just because it's a percentage of premium and the premium base is larger. Also, you'll notice that the MOTA trend assumption is 10.16%, which is higher than previous years. Mercer just updated its national trend guidance upon input from our national carrier partners that we work with. Often our new medical trend midpoint is 9%, reflecting the reality of the healthcare system, which we'll talk about shortly. And the current pharmacy trend assumption is 10%. So we feel like this trend, while higher, is appropriate for us in making sure that we're not underfunded next plan year. The Kaiser trend for them is 6.6%, which is similar to what was used last year. And again, there's some different dynamics at Kaiser. All right, so let's look at the dental renewal assumptions. Thank you. So just reflecting the different dental provider networks and delivery systems, with Willamette Dental Group functioning more like Kaiser in this scenario than Delta Dental. The trend assumptions are 2.6% for Delta Dental, Kaiser Dental 4.3%, and Willamette Dental for 5.9%. Just because it's been a year since we've talked about trend, you can just think of that as OEB-specific medical inflation. And so absence of any other factors changing, that's just simply the anticipated increase in price for services. And then lastly, we have a slide that lists the different vision assumptions. We have 3 options for vision, MOTA, Kaiser, and VSP. The MOTA trend assumption and VSP trend assumptions are both 5%. The Kaiser vision is included with the medical renewal calc, and so the vision would be trending at the same as the medical, 6.6%. Rose, if we can go forward a slide. Okay, thank you so much. So let's pause here. So we just saw that overall, the medical, dental, and vision renewals are coming in at around 13.5% is our starting place with a gap of about 111%. And we saw that these are historically the highest increases since before the pandemic that we've had to work on together. In this slide, you'll see in the top purple line, and the purple line is the results of a survey. Mercer surveys our clients nationally to ask about their renewal increases. 9.2% was the anticipated renewal increase. I'm sorry, that should say 2026, the top of the slide. 9.2% increase before benefit changes. You'll notice that 9.2% is the highest of any starting renewal, even going back to 2015, 4 years before the pandemic, 5 years. You'll also notice in the black line underneath the purple line that every year employers are having to make difficult decisions in the commercial market involving benefit changes, plan design changes, network changes, restrictions in covered services, anything that they can do. In the commercial market, we do a lot actually with premium and contributions that we don't do here on the OEBB board. But in general, employers are buying down the renewal increase with these changes. And if for 2026, they landed on 6.7%, so roughly 2.5% worth of changes. Plotted in yellow is overall inflation. Frustratingly, inflation had its spike. We all remember that back in 2022, and is now lower while health continues to increase. And then the blue line always is workers' earnings. And I know we feel that in particular with our population of educators and assistants. So we all do keep that in mind. And it's one of the reasons why we endeavor to preserve benefits in their current form as much as possible. Let's go forward to the next slide. So this is the overall explanatory story, the summary of what's going on in the healthcare market broadly as we see it. And then we'll delve into each of these pieces more. If I had to pick one word that really stands out as the word above all to describe what's going on in the healthcare market this year, it would be technology. The role of technology in innovation. And we've talked about that over and over again in terms of pharmacy. And Nathan Merrill will talk about that more today and answer your questions about pharmacy innovation. But we see technology driving innovation in care. Technology is driving changes in how providers bill and reflect the care that they've been providing to our patients as well. And really leading things off is that hospitals and provider groups are under financial strain. Rising operating costs from wage pressure, inflation, and tariffs, so higher operating costs. Also, we've had a prolonged higher interest rate environment now, which makes capital improvements more expensive. And reimbursement is a double-edged sword. Reimbursement, as us, the employer, on behalf of our members, thinking about wage growth, we endeavor and we advise our carrier partners and expect them to manage provider rate increases as low as possible. In fact, that was the genesis for the 3.4% cap on renewal increases. Part of that was tied to the hospital reimbursement cap from Senate Bill 1067. The flip side of that is if you are a provider group and you're faced with historically high inflation, sometimes it can feel like that lower reimbursement rate pressure is not enough to cover your operating expenses. So then here's the role of technology, in particular AI-powered software. Hospital and provider groups respond to remain financially viable, and they do this in one of a few ways. They raise prices when possible. Although there are some legal and practical limitations, we just talked about one of those with Senate Bill 1067. They use other revenue optimization techniques. Really, I feel like that's an emerging story of this year, in that it's not a topic we've talked about before as an OEB board. Consolidation. We've seen that in Oregon, actually, both some proposed consolidation that didn't happen. There's some currently in the works, and also some has happened. The positive side to consolidation is it can keep troubled rural hospitals afloat. There's a cost to that. And then, unfortunately, sometimes it does result in hospital closures, or closures of parts of hospital, in particular maternity wards in rural Oregon is something that we've talked about before. So as providers seek to get additional revenue to address the financial strain, the additional revenue translates into additional costs for employers, such as OEB. And then underneath that all, putting continued pressure on the whole entire system from a cost perspective, also somewhat of a moral and ethical pressure as we strive to think about what to do with these innovations and how to extend access to our membership. Innovation continues to transform care at high cost to employers. So let's go forward one slide and just look a little bit more at financial strain. So we'll talk about financial strain, and then we'll talk about some of the innovative ways that providers are trying to remain financially viable. And then I'm going to hand it over to Nathan Merrill, who's going to talk about some really interesting things going on with pharmacy. Hospital and provider groups are under financial strain. Again, rising operating costs have outpaced reimbursement increases. The pressure between non-labor costs in particular. You guys might remember that coming out of the COVID-19 pandemic, there was a wave of early retirees as people addressed burnout and really difficult working situations. We brought in a bunch of temporary workforce, which was very expensive. That was one of the reasons for Kaiser's higher renewals earlier on. Also, non-labor costs have gone up. We just looked at that yellow line on an earlier slide, the spike in underlying economic inflation in 2022. Supply chain disruptions continue to happen. We've seen that impact the GLP-1 market over the last few years. Also, tariffs are a factor. The higher cost of capital is making capital improvements for facilities that have aging buildings more expensive. Shifting payer mix as the American population ages and more people roll onto Medicare. Medicare rates are lower than commercial rates. If we think back to Senate Bill 1067, Senate Bill 1067 generated savings because it capped commercial hospital rates at twice Medicare, which only would have generated savings if the commercial rates were above twice of Medicare, just to give you a way to relate those two together. Provider consolidation, while helping smaller, especially rural providers and independent groups stay financially viable, also reduces choice of provider and competition amongst providers. In Oregon, there's an innovative approach to this. There's an agency through OHA called the Healthcare Market Oversight Program, which reviews proposed consolidations. I won't go into it here, but I will say that there's some really interesting recent cases, in particular the OHSU legacy merger, that the OHA's Healthcare Market Oversight Program worked on and commented on. If you're interested to look, it's a good example of this process in action and the value of OHA. In Oregon, we're still struggling to attract and retain enough healthcare workforce to meet the challenge, to meet the demand. So a 2025 assessment shows that our workforce is growing. And those were national trends, actually. The workforce is growing by quite a bit now, but we still need more providers. So we grew 15,000 providers over the prior year, but we still need another 18,800 providers, especially, of course, in rural Oregon, which I know we know, but it's important to mention. Let's go forward a slide and let's talk about something that you may not know a whole lot about because it's new this year. Thanks to AI, I suspect we'll be talking about more new things together as time goes on. automation powered by AI is really revolutionizing the way that provider groups generate revenue. And again, I don't want to place blame or accuse provider groups of doing anything untoward. It's really leveraging technology to increase revenue through legal means and channels. Essentially, the value of AI to provider groups is that when you have AI function to, let's say, document a visit in real time and document the procedure codes, take visit notes, document a patient's diagnosis, it saves the provider the time and energy of having to do that, which frees the provider up for more appointment slots to see more patients, which translates into an increase in volume, which we are seeing. But the flip side to that is that it does increase costs to employers because this ambient software is more accurate and comprehensive than human note takers. More visits and are being captured during appointments than prior. So it used to be on average 3 diagnoses per patient, and now it's 4.1 diagnoses. This was according to a study. The result of increased complexity is that more costly, complex visits can be billed. So both with the emergency department visits, with inpatient admits, even with simple office visits, there are levels from simple to moderately complex to very complex. And the billing has to be justified with comprehensive provider notes. But if the comprehensive provider notes support higher complexity visits, then providers are able to bill and receive the higher revenue associated with those visits. And then it was very interesting to think about the downstream. Again, it depends on if you're on the provider side or the employer side. It's why we have to be a little bit careful when discussing these factors. Because early studies show that it does reduce burnout and increase provider satisfaction. It also increases appointment availability, which we are always striving to improve access, so that's a positive. Also, we need to be mindful that when we increase access and those appointments are filled, that translates into increased costs for OEB. We hope we're seeing patients and affecting treatment that down the road will improve overall outcomes, but not in the short term. I'm going to pause on the financial aspects of trend before I pass it over to Nathan to talk about pharmacy. Robert?
Yeah, so I kind of understand the slide, and it's not about overbilling, it's just about being able to bill better, I guess is the way to phrase it. So yeah. What's the long-term strategy around that? Or is that just something we have to bake in from now on? Is this going to be an ongoing issue every time we do a renewal now?
Yeah, you asked the question of the day on this topic, Robert. There's a really interesting article, I think it was by the National Institute of Health, that talks about this dynamic that's going on with AI and technology, whereas there's innovations in the provider billing and note-taking and revenue optimization, then there are advancements in the carrier's ability to detect changes in provider billing patterns and say, hey, wait a minute, what's going on? And then the provider technology will adjust and say, oh, okay, well, now we have an increased denial rate with these kinds of procedures because we're not using this terminology. Now our AI software should use these kinds of words. And so then the provider optimization software will adjust. I think it's a new normal. What I don't know yet, because it's too new, and also because I personally find it very hard to wrap my mind around the full potential of AI. I don't know if it's going to be continued innovation for a few years, or if it's going to be more like a step function where there's, an adjustment period like this year where there's a very clear step up in how things are happening and will go on for a few years until the next major iteration. I think what's important, and hopefully Craig can talk about this too in a little bit when Moda speaks, is that we're all aware that it's happening. And at the end of the day, we are focused on making sure that the quality of the care is the same for our OEB members and the quality of care is being provided as it's being billed. There are some alternative payment mechanisms, I think, Robert, that deal better with this, that are more of a long-term strategy that we're thinking about with MODA. For example, in a capitation arrangement, a provider, essentially Kaiser is a fully capitated model, and that we pay Kaiser a premium and they manage care. In a capitated model, it doesn't really matter all of those schemes because it's not going to generate additional revenue to the provider. So perhaps one thing that we need to do as an OEB board, along with OHA and your carrier partners, is look at alternative reimbursement methods that get us out of that cycle of back and forth trying to outpace each other in terms of innovate, detect. So it's a new problem, and we are thinking about it, and we will continue to keep you updated.
Kirsten, is it fair to say that, PEB and OEB start their renewals for 2027 this year earlier than most other groups? So we kind of end up wrestling with some of these trends or coming to grips with some of these trends a little bit earlier than the rest of the market. But yeah, it seems like that's been kind of a factor that's resonated over the years where we get into these renewals so much earlier than the rest of the market that we start hearing about the same kinds of things a few months after that.
Yeah, it's so true. I'm just going to make a note, Ollie, also Rick, and then Robert, we'll go back to you. So I'm just making a note to make sure that I capture everybody. It's true. In the commercial market, most of our clients are 1/1 renewals, and they'll typically see a first renewal calculation maybe in May, with a final renewal calculation later in the summer in time to make decisions for a fall open enrollment. And so it's maybe a cost, also a benefit. One of our OHA missions is to be innovative in the field of healthcare and in transforming healthcare in Oregon. And because we start on the renewal early, and as part of the due diligence that Mercer does, we do a trend deep dive and push on your carriers like, yo, what's up? Why 18.3%? We get to ask all of these questions much earlier, and then we ask them of our colleagues and we ask them of Mercer nationally, hey, what's going on? And we can push things that way too. It also means, Ollie, to your point, that sometimes, we have to wait a little bit to get the answers to those questions. But we are thinking about the 27-28 renewal while we are thinking about the 26-27 renewal because of what's going on with trend. Rick, you had your hand up.
Just two things. One, I think all of the providers now are using recording devices to record their notes with patients. So that sounds, from what you're saying, like every time a patient asks another question, that can generate another billing code. And then the second thing is you talked about the capitation plan as a strategy for addressing cost, which in the past, capitated plans the concern was that they get paid, the motivation is to do as little as possible and not spend money. And then, so maybe if there's a way to pay based on outcome rather than capitation or fee for service. That's all I had. Thank you.
Yeah, thanks, Rick. They're called ambient scribes. That's the aspect of this technology that you're specifically talking about that listens in on the visits and takes notes and records diagnoses. So it would really depend on what gets discussed between the provider and the patient during that visit. But the result is that the average diagnosis count captured increased from 3 to 4.1% in one of the studies. And this technology, it's interesting about it, and thinking back to one question that you asked, Robert, about is this the new normal? is that ambient listening technology really became widely available in late 2024 and does not appear to be 100% adopted nationally across all payers at this point. So potentially there's a little bit more to go from that direction. I think, Rick, you're echoing the usual concerns about capitation that are really important to keep in mind. So thank you for that. There are different tools now to address those concerns than we had maybe 10 years ago around performance guarantees, outcome monitoring, even the data that we have available, more clinically outcomes-focused data. Also, there are different ways to do capitation, types of services, for example. So that's why it's an idea for 2027, because as you raise the concern, capitation is a bigger issue than we have time for 10/1 of 26. Robert? Oh, I think you're on mute, Robert.
Oh, such a rookie move. Have you been able to quantify what portion of the 18.3% increase is attributable to the ambient scribes issue? And if not, then how are we going to track it in the future?
Yeah, here's the difficulty with that. This is the problem that we're thinking through, the question that we're thinking through. Normally, we think about trend in terms of unit cost. And historically, we've talked about unit cost as being relatively controlled for OEB, thanks to Senate Bill 1067, because our trends are anchored to Medicare trends, which tend to be both lower and more stable. And then there's mix of services trend, which is like GLP-1s are a really great example of how mix of services as new, innovative, expensive, better, in some cases, often novel therapies come to market, not just drugs, but across the board. There's lots of examples going back in time, MRI machines, for example, new technology coming. And then a certain protocol switches over to the new technology. So the mix of services is now a more expensive mix. That's a trend driver. But now we have this issue where we know chronic condition prevalence in our population has gone up. But the way that we think we know chronic condition prevalence has gone up is because we look at the claims at what diagnoses are recorded. But if the diagnoses that are recorded reflect to some degree provider revenue optimization strategies and not an actual change in the underlying morbidity of the population, we can't tell those two things apart, because the one we know from billing, and we know that billing has changed. And so the reason why I say, no, I can't quantify, Robert, is because we haven't figured this out yet, but we're actively working on it. If we carve out a portion of that 18.3% for unit cost trend, a portion of it for utilization, there's a bigger portion remaining that is some combination of provider revenue optimization and chronic condition burden. And because they look the same to us, more diagnosis codes, we are still thinking about how to parse those apart. But I would love to keep working on that and see if we can't bring that back in April.
Thanks.
Yeah, these are all really great questions. I'm sure you'll have more. I'm going to invite Nathan to hop on. Nathan, will you please spend a minute also introducing yourself to the OEB board? And then Nathan is going to talk about trends in pharmacy.
Great. Thanks, Kirsten. My name's Nathan Merrill. I am a pharmacist. I have been for a little over 20 years now. My previous role prior to starting with Mercer was working for OptumRx, and I was there for about 11 years, overseeing a number of their clinical programs, primarily the utilization management team, as well as their drug utilization review programs. And I also sat on providing clinical support to the P&T committee, helping answer questions around clinical and formulary strategies. And then joined Mercer last fall And so I'm a relative newcomer, but I'm excited about the opportunity to speak with you today. So as Kirsten was saying, I'm going to speak to you about innovation within the pharmacy space. And when you think about innovation, it's one of those buzzwords that gets thrown around a lot, all across, all different types of industries, and I think loses some of its meaning with folks trying to make it sound like they're being modern or unique, or new and cutting edge. But I think it loses its meaning because everyone's trying to be innovative, and I don't think folks truly understand or they lose sight of what innovation means. So when I think about innovation, I think about creating value um, through novel solutions to meaningful problems. And when we talk about innovation in the pharmaceutical space, I think that that's exactly what we are seeing. And innovation can be a great thing, but we tend to see it as sort of a double-edged sword where there's a lot of opportunity with innovation in terms of disease management, but there's also challenges with high costs. And I'm going to kind of take you through some of those examples, and then we'll be happy to answer whatever questions you may have. So looking back on innovation within the space, probably around a decade or so ago was the introduction of these breakthrough cures for hepatitis C. And that was the buzz. That was all anyone was talking about because you were seeing these high cost therapies, but they were actually curing people of their hepatitis C. So while they were a high cost up front, up to 24 weeks or so of therapy, and the member or the patient was done, right? They were free from their disease and there was no more medication to be taken, and all these long-term costs were then eliminated or mitigated because their disease was effectively cured. So you don't hear anyone talk about hepatitis C anymore. Now, shortly after that, we started to see the introduction and the arrival of these gene therapies, which were quite a breakthrough in terms of the technology, where we were actually introducing medication into the body that was then going into and repairing or removing or modifying patients' genes to effectively cure them or extend the life of folks with these very rare diseases. And Zolgensma was sort of like the poster child for this back when that came out, as we saw a price tag above $2 million for the first time. We hadn't really seen anything like that prior to the launch of Zolgensma. And since then, with regard specifically in the cell and gene space, that's very common to see dollar amounts in that level of range. We're starting to see more innovation with HIV PrEP that's gaining traction, a lot in part due to preventive care mandates. So you think about, from a pharmaceutical manufacturer's perspective, if a particular medication can be used to manage a condition that there's mandates saying you have to cover these therapies and you have to do so with minimal barrier, if any barrier, to access, and the patient should have no cost share involved, you're going to see sort of a mad dash to be the first at the table, or to come to the table with solutions to help address that condition. So we're starting to see the pipeline for HIV PrEP in particular grow, and really the goal of the products we're seeing in the pipeline, it's a shift towards more long-acting, user-friendly options. You're seeing longer 6-month injections or monthly oral formulations, again with the goal of improving adherence and expanding access with less frequent dosing. The next bullet point, we think about advancements we've seen with regards to chronic conditions. So now sort of moving away from rare conditions or specialized conditions, chronic conditions such as weight management, diabetes, a lot of rheumatology, dermatological, and gastrointestinal conditions. We saw the rise and continued rise of these biologic anti-inflammatory therapies. Think of Humira, Stelara, and the like, which really dominated pharmacy spend for several years up until GLP-1s, and we all know what happened then. So GLP-1s, while their costs are high, but maybe not as high as some of these other biologic anti-inflammatories, because of the sheer volume and utilization of these products, that's where we're seeing the high costs to employers with those particular products. I mentioned briefly with Zolgensma gene therapy, cellular and gene therapy, because of its novel delivery mechanism, novel technology, there is a high price tag there. And you think about initially with these therapies, they're treating previously on or under treated conditions or orphan conditions. And so not a lot of patients that are ideal candidates for these therapies. And in order to help recoup investment on the research and development of these particular products, that's where the rationale or justification for these high price tags comes. However, we're starting to see within this particular space a move away from rare disease, expansion beyond rare diseases, and some of the blood cancers and things that these products typically targeted, a shift towards more solid tumors and autoimmune diseases, things like lupus, multiple sclerosis, and we're seeing expansion further into the oncology space, into cardiovascular disease and metabolic conditions where these products could be used potentially for weight management. So you think about the price tag that comes as a result of this technology, and now the potential for these therapies to be used for a lot more common conditions. Those are things to start thinking about. How do we get in front of these particular potential costs, as it's no longer reserved necessarily for very unique or small populations? And then briefly speaking about oncology therapy, we're starting to see a lot more targeted therapies moving away from the broad chemotherapies that were really affecting all sorts of cells within the body and causing all sorts of damage and side effects, into targeted therapies that are really looking at the specific mutations involved in particular cancers and helping focus their effects on those specific cancer cells as opposed to other healthy cells within the body. So that's where we talk about opportunities, the benefits that we have seen and are seeing with innovation within the pharmaceutical world. Then we talk about the challenges, the primary being the inflated costs. And an example that was called out here is looking at OEBB's pharmacy spend over a 5-year period jumped roughly 10% in that amount of time, while enrollments went up less than 1%. So you're seeing this acceleration in pharmacy spend, greatly exaggerated compared to just member utilization. So higher price tag, fewer prescriptions, and it's something that is not slowing down anytime soon. In fact, looking ahead to the pipeline, more than half of the drugs in development are considered high-cost specialty drugs. And again, there's a number of market conditions I've spoken to that are behind this, and it's things that we're sort of doing behind the scenes to help understand what can we do to help manage access to these while being responsible to your members and your bottom line. So that's my presentation here. I'm happy to open up and take any questions that you may have.
Any questions from anybody? so we can move to the next part of the presentation.
Thanks, Nathan. Rose, we'll
Thank
go
you.
to the next slide, please. Now we're going to talk about the national healthcare trends as they relate specifically to OEB. The trends experienced nationally are also impacting OEB. Medical trend is driven by cost increases, unit cost increases, billing practice changes, as we've discussed, and then volume increases, which are an indirect consequence/benefit, depending on how you see it, of billing practice changes. Pharmacy trend, as Nathan just described, is driven by innovation, which leads to a higher cost per script, targeting conditions that historically have had few treatment options, which means that there's natural interest and uptake from patients. Some strategies have resulted in savings, and we'll see the evidence of that on the next two slides when we look at OEB's trend, both with Kaiser and MODA, but they are overshadowed by upward pressure. Revenue maximization strategies do appear to be a large driver of the excess medical trend, and we're going to try to quantify that for you at the April meeting. Unit cost strategies alone are not enough to manage medical trend. We need to manage the overall number of services that members are seeking. And this is the difference between, so what is being talked about in this paragraph? It's the difference between the cost per service and the total cost, which also depends on what services and how many of them. And it's those latter two things that we need to focus on. Senate Bill 1067 and carrier negotiations help us tremendously with stable unit cost increases. However, there is still an aspect of our work to do together and with our carrier partners to manage the overall number of services members are seeking. We don't want to withhold care. We really want to make members well, so they're getting less downstream care. And we also need to manage the way that providers are billing for services, the number of procedures, diagnoses, the complexity, things that we talked about earlier. We gave one potential example of an idea that we're thinking about for 2027 related to, is there a role for capitation to help bring revenue stability to providers and also rate stability to OEB? And it's just an example of one idea we're working on. The best approach, now more than ever, and this is not new, we've talked about this every year, we've talked about this, but the cost pressure related to care really emphasizes the importance of wellness and prevention, which reduce the need for downstream services. And I do think that's the best, healthiest way is for us to eliminate avoidable care entirely by making our population healthier. Let's look at the next slide. We have two slides. They're identical. And before I talk about them, I'll orient you to our color scheme. First, we're going to look at MODA, and then we're going to look at Kaiser. There are 4 lines, gray, yellow, blue, and green, each representing different aspects of trend. The blue line is the medical trend. We look at things on a rolling 12-month average. That's what R12 means. Otherwise, medical claims spike too much from month to month. It's hard to see a pattern in the data. But when we look at a 12-month average and then plot that moving average over time, the pattern becomes more clear. We have the rolling 12-month average. And again, we're looking PMPM. So this is per member per month. We have the pharmacy rolling average in green. In the yellow line, we have the trend in the number of patients per 1,000 members per month for OEB. And then in gray, we have the average allowed per claim. We have circled, just to facilitate our conversation with you today, we have outlined in those dotted boxes the areas of focus on the graph. We actually go all the way back to 2020 because we can see the COVID mess that happened to trend, all the impacts on cost and utilization during and immediately after the pandemic. It will be more pronounced even for Kaiser. But we see that, and then beginning in about 2022, we can see a couple interesting things start to emerge. So first, let's look at the yellow line. So this is the trend in patients. We can see we're going to see similar trends both for Kaiser and also MODA with this yellow line, which is beginning in early 2023. We have a slow and steady increase in the number of patients getting care out of our population. This is not, and again, none of these things are necessarily bad things, right? More care is a double-edged sword. Obviously, we want people to get the care that they need. Our primary mission is to make people well. Also, more care is more dollars in the short term. We can talk about long-term health outcomes, but in the short term, it's more dollars. The slow and steady increase is related to two things. Our carrier partners, at our direction, also at their own impetus, undertook efforts to increase their provider availability, which you might remember was hit hard after COVID. We had long wait times, especially for elective procedures. There was a long wait time at the dentist because of a shortage in hygienists, for example. So we had a shortage of providers, and our carrier partners worked hard to increase appointment availability over time, and there were patients waiting to fill that demand. And so we see this slow and steady increase in the number of patients. It's been leveling off recently, so maybe that means we're at a good provider member demand mix. Let's look at the green line next. So we have boxed basically a mountaintop in the green because we want to illustrate to you with MODA beginning in 2023, we saw an increasing pharmacy trend coinciding with an increasing availability and uptick of GLP-1 and other high-cost drugs. And then the MODA pharmacy trend starts to decline again, and we crest the mountain peak and we start to go back down. And that's because OEB board did benefit from two pharmacy initiatives. Humira, the Humira biosimilar, was a cost savings lever, a big one, both for Kaiser and MODA. And then also the OEB board voted 2 years ago to implement the Copay Max program, which generated a significant amount of savings as well for OEB. So there were successful pharmacy cost management strategies that were implemented that brought the pharmacy trend back into control. Now that we have fully incorporated those savings levers into our experience, now we're going to start trending up in the absence of any new additional strategies. We'll start trending up at normal pharmacy trend again. Let's look at the medical trend next, and we'll save the average allowed per claim for the end. The medical trend is in blue. And you can see we've boxed beginning in mid-2024, but coincides exactly in the data to what appear on paper to be changes in billing practices related to increased complexity and volume of services, which are outcomes of revenue optimization software. So the OEB medical trend really was had an increase again. So from 2022, mid-2022 really, up to mid-2023, OEB medical trend increased. And the factors we talked about at that time was increasing chronic condition prevalence, increased appointment availability, more services, a higher morbidity within the population coming out of COVID, potentially because of deferred care. So there were other dynamics. Also, inflation was a big factor at that time period, dynamics leading to higher medical trends. And then our trends leveled off a little bit, but really had this rather striking sudden and steep acceleration beginning in 2024. The allowed medical per claim really is a reflection of the average billed and allowed per contract, the average allowed per claim that members are having. And you'll notice that the average allowed per claim coincided directly with that same time period, a pretty sudden and striking increase beginning in about mid-2024. Let's look at these same trends for Kaiser on the next slide, please, Rose. Kaiser will have some differences for a couple of reasons. There are some bigger differences around timing. So, for example, a benefit of the Kaiser HMO model is that they can implement and mandate an immediate switch to the Humira biosimilar Angivita, and that change was made either the month of or the month after that the drug became available. So it was immediately implemented across the board for Kaiser, generating immediate savings for OEB. And then also a benefit to OEB is that Kaiser's process of integrating new alternative therapies into its treatment protocol, for example, with type 2 diabetes, there's a different process at Kaiser that can sometimes take longer. And so the GLP-1 spike was deferred at Kaiser and begun later. So we can see that in the green line, that Kaiser's green line really started to escalate almost about a year or two after MODA's because of those factors that I mentioned, the biosimilar earlier and the GLP-1 later. Kaiser's medical trend peaked earlier also, and they'll talk about the timing reasons for that with contracting since they're an HMO model. Their medical trend has been coming back down, and that's why we were able to receive a 3.81% medical renewal from Kaiser this year. Similar trends in the number of patients within our population seeking care. In early 2023, we started to see a slow and steady increase in patients, which really started to level off in early 2025. So maybe we're at a good balancing point there with availability and demand. And then the allowed medical per claim also peaked earlier for Kaiser, again, potentially related to the adoption of revenue optimization software, the ambient scribes within their own system, but also related to the timing of contractual changes related to their delivery model. So I know we had scheduled on break to go to break at 2:35 and then have our trend presentation start at 2:45. So we'll definitely have some time for more questions. And then also, Rose, we probably want to do a check, or Enrique with the carriers to see if they're ready to go earlier after break.
Yeah, I think that would be great. I'm sure everybody will be happy to move the agenda up. And so if we can check with the carriers, that'll be great. Are there any questions for Kristen, while we check on the carriers? Sally, go ahead.
Yeah, I mean, I have a question back quite a ways, right? That MODA last year raised deductibles by $300 and copays by $5, introducing Garner in with the, I guess, hope or intent that, that would help offset some of the costs. But now we're seeing an 18% round one increase. Why? I guess I'm just a little taken aback by the raise in premium, the raise in copays, the introduction of Garner. Is Garner not effective in helping offset those costs? How is that going? And why are we seeing 18%?
Yeah, it's normal to be taken aback, Sally. We were also, it's a kind of a shocking increase, frankly. Garner did go into effect. We did increase deductibles and copays, and it makes you wonder what would the renewal increase have been if we didn't do those things. MODA is in the process of estimating savings and validating with Garner. One thing that can be tricky about new programs is that uptake is not instantaneous. So the target Garner utilization was 30%, although of course we hope to see as much utilization as possible. But it's not like that happens all on 10/1. In fact, there's a kind of a couple different pieces of timing that need to happen. The members need to become aware of Garner and sign up. But I think more importantly, they need to have a reason to seek care. And something that we have been wondering about for OEB is because we usually have a seasonal care pattern where we have more elective care, think hip and knee replacements or other bigger procedures that might take somebody out of the school environment for multiple days. we have a push on those in the summer. So maybe the Garner engagement and utilization push is going to come still. But we need members to see Garner and have a change in their provider to a lower cost provider in order for Garner to generate savings. So our ask and modus also of Garner was to try to estimate the savings that they've had so far this year for this plan year. So we'll bring that to you in April. But I do just want to acknowledge your frustration about the starting place, especially because the deductibles and co-pays were increased for everybody across the board, which those changes do start generating savings immediately as well. Deductibles are first dollar care unless it's a copay service.
Do we know what the Garner utilization is?
We do know what the Garner utilization is. I don't know it off the top of my head, but it is known, Sally. So let me send a note and get that number and I'll put it in the chat for you if that's okay.
Yeah. Thank you.
Yeah.
Anybody else for questions? Bill, go ahead.
Just a thought, really, more so that, we're basing these trend rates based on the previous year, but we do know that there's some changes that are occurring in the coming year, Medicaid refunds, stuff like that are going to affect stuff. So I realize we can't really predict and put that stuff in, but just a thought on or comments about that.
Yeah, thanks, Bill. Changes in the regulatory environment at a state or federal level cause insecurity and worry about the financial outlook. And I think certainly are a factor for providers as they think about what to do with their billing practices. Sally?
Yeah, I have one more question. I didn't see it on the agenda. So I know last year we were, or maybe not last year, but like we were discussing at some point in time, forgive me, the potentially raising the cap for 1 year. Where are we at with that? I know that we had talks of being able to see what it would look like if we raised the cap for 1 year and or like lifted it, right? And or if we just had to make plan changes so that the board could review that. Is that still the plan? If so, where do we stand with that?
Ollie, do you want to give an update on?
Yeah.
Thank you.
Yeah, sure. Both boards, PET board and OEBB board, have legislative concepts drafted in the process for moving forward to the governor's approval. They're currently still in the agency process, approval process, but kind of taking a couple steps forward, still alive. But these would be for amending our statutory language that sets that 3.4% annual cap. I think we have 3 or 4 different options, Sally, that we've proposed. I think it would be, when the legislative concept is considered, we would talk through with the governor's office or through the legislature what would make the most sense, and then adjust the language from there. But it still is a process, and unfortunately would be again part of that 2027 legislative session.
Okay, I think maybe I didn't ask the right question.
Okay.
That we had discussed for 1 year, just only 1 year, removing the cap, which is, from my knowledge, allowed for 1 year, right? And then putting that cap back on. So in the interim, right, while legislative changes, in the works to change the current cap that we have, we had discussed lifting it for 1 year and putting it back on so that the plans could kind of reset.
Mm-hmm. Yeah, unfortunately, the current statute wouldn't allow for that. So that is providing relief for 1 year or a period of time is one of the options that we initially proposed for that legislative concept. But again, it has to go through the process and actual legislative process before a statute can be amended. But the OEBB Advisory Committee as well is looking at their own legislation. So beyond just the PEB and OEBB board sponsored legislation, the OEBB Advisory Committee through the various constituencies could present something through legislative committee. So that's actually going to be discussed at the OEBB Advisory Committee meeting in the next month.
Thank you.
Yeah.
Go ahead, Rick.
I would just ask a couple of questions. Number one, if the legislation you were just referring to, Ellie, were passed in the 27 session, would that be implementable for the renewal 10/1/27, or would it have to wait until 10/1/28? That's one question. And the second question is probably maybe for Kirsten or Mercer. And thank you, Kirsten, for your excellent presentation. It's been very thorough. But should we infer anything from these rate increases about 27/28 rates? Those are my two questions. Thank you.
Yeah, for the first question, yeah, I mean, it really depends on the timing. You know, if it got into a bill, what the effective date could be. You know, I think it would be a reach to say it would become effective 10/1/27, but it's possible. There are emergency clauses, which, you know, obviously we would push for, that would take effect right after the legislation sine died. So that's kind of, you know, we'll talk more about this, but we're looking at a 2-year strategy this year and the next year to hopefully kind of blunt some of the just 1-year impact. I think, you know, we have 2 more months of claims experience as part of this renewal that we're hopeful will bring down that 13+% starting point. But what was the second question, Rick? Sorry.
Should we use this data, the cost data we've seen today, to infer anything about rates in 27/28?
Yeah, I mean, it's looking like it's moderating. I mean, Kirsten, you can probably speak a little bit better about this than me, but you're not seeing like the big drop off from, I guess that was 2021 to 2022, but we are seeing some moderation going back to maybe a more normal kind of level of claims and cost and utilization. Would you agree with that, Kirsten?
Yeah, I think I would put it this way, Rick, and it's very difficult with OEB, which is a 10/1 plan year, with also the summer seasonality push, to have a lot of confidence in how the current year is going as of March. Because really, even though the month of February is complete, we don't have much data on February. We have like pretty moderate data on January. So it's trying to look at the whole year based on OEB's first quarter of the plan year, which we know is always low because it's the first quarter for educators and assistants. So that's one of the things that's making this difficult. It looks like things have moderated a little bit, but at a higher level than we're used to. So maybe it's not accelerating as much. I think we're going to be in this climate where we are facing pharmacy innovation every year. the specialty, the pharmacy pipeline is now more than half specialty drugs. And the trend is only continuing that way because they are more lucrative for pharma companies. And we'll continue to face those questions. We're still grappling with GLP-1 drug coverage for weight management, which is not the newest innovation. So they're very challenging for us in light of innovation, in light of inflation, what's going on in the workforce, uncertainty, all these things that we've been talking about, AI, which feel like is a huge unknown quantity. 3.4% is a very, very stringent target compared to the factors that we're dealing with. I would love for next year's renewal increase to be lower than it is this year. You know, maybe it would be high single digits, which would roughly be a trend increase, honestly.
And I would just add, you know, the 200% hospital cap is tremendous for both PEB and OEB, and does, you know, moderate some of the major swings. But when that went into effect in 2020, it really only impacted meeting that 3.4% test that 1 year, because each year that baseline resets. So it's while it's saving money every year and meeting that 3.4% each year, that the impact really is only felt that 1 year, which is why it's really difficult to justify, you know, a year where you're starting at 13.4% and getting down to 3.4%, making, you know, a bunch of changes to plan designs or your program just to meet that 1 year of target. So that's what we're hoping to modify through that legislation.
Well, thank you very much.
Yeah.
Any other questions, OEB board? Otherwise, Enrique, I'll pass it off back to you to send us to break.
Awesome. So we are ahead of schedule for now. So we'll be back at 2:36. 6-minute break. Thank you. All right, everybody, we're back in business. Thank you very much. I know it was a quick break. So if you need a minute to turn the camera on, that's totally fine. Hi, Bill. Welcome back. Hi, Rick. Hello, Robert. Awesome, Christine. So whenever your next set of members, Craig, Senior VP and Chief Actuarial, and Kaiser Mark Mueller. Go ahead.
Should I just go ahead?
Yeah, go ahead. Yes.
Okay,
ahead,
great.
Craig.
Thank you very much. I'm Craig Anderson. I'm the Senior Vice President here at MODA and also the Chief Actuary. And I just wanted to start by acknowledging the challenge that we're all facing here with our renewal. I hope to address as much of that as possible in our presentation today. I've been working on OEBB since its inception in 2008, so I just want to echo Ali's comments earlier. Appreciate Kirsten's comments too, that we're working on this collaboratively, and we'll do everything we can to help moderate this for the benefit of the MODA, or for the OEBB members and the OEBB board. So I have a presentation here that I wanted to go through. I did take note of some of the comments earlier in the conversation, so I'll try to touch on those. But please feel free to interrupt me at any point, and I will be happy to answer any questions that you have as we go through this. So Rose, you can go to the next slide. So some of this will be a repeat from what you heard from Mercer, but I just wanted to give you the carrier's perspective on some of these dynamics that we talked about earlier and highlight a few things. So as you heard, and probably heard through multiple presentations, there has been a lot of financial strain on providers, hospitals in particular. And something I want to note here is that we do have this unique situation where we have both the Senate Bill 1067 hospitals and the non-1067 hospitals. And something that's worth highlighting is even for the Senate Bill 1067 hospitals, we did see CMS pass along higher increases. So the Senate Bill 1067 hospitals are tied to 200% of the CMS fee schedule, and even those were higher than usual, particularly in 2024. Kirsten spent a lot of time talking about revenue optimization and the sophisticated billing practices. And something that I will go into more detail later on a slide dedicated to this, but the best way to determine whether these increased billing practices are valid is to actually get in and look at chart notes. And that's a intensive process that we go through, and I'll talk about that in more detail. And then lastly, Kirsten talked about consolidation. And in addition to the healthcare market oversight program that she commented on earlier, the legislature's also taken action to try to address consolidation. But as it was stated earlier, there are pros and cons of that. And so we're probably seeing some of the downside of that in this renewal. You can go to the next slide. So I thought I want to spend some time on MODA's contracting. It is different than what Kaiser does. There might be a bit of a lag in it because the impacts to the providers are delayed a bit because we have contracts in place, and it's really at renegotiation where we see some of the impacts that the providers are feeling. So there's a little bit of a difference there between an HMO model and what we are as a PPO. But just some high-level talking points about how our contracts are structured. We have what are called both fixed contracts, which have fixed reimbursement rates that we renegotiate every year with providers. And then we also have some contracts that we refer to as automatically renewing, or the other term that's used is evergreen. And those are typically, the latter are typically related to hospitals that are non-1067 that are reimbursed on a percent of billed charges. And that is done for a few reasons. One is that doesn't require renegotiation necessarily every year, but it is susceptible to the impact of providers increasing their billed charges, particularly hospitals. And I should mention there's this term called charge master. So what hospitals use are what they call charge masters, which is really just a menu of their services and what they charge for those services. And I'll go into more detail on that later, but that's a term that I'll reference as we talk about the non-1067 hospitals. And then on the professional side, or the non-hospitals, we do have some what we call automatically renewing contracts when they're set as a percentage of Medicare. Those are a large number of providers, but they're typically smaller providers that we do that with. Most of our larger professional providers, physicians, we do a fixed contract that's renegotiated every year. Speaking specifically to Senate Bill 1067 versus non-1067 hospital contracts, all of our 1067 hospital contracts are what we call fixed contracts. So we do renegotiate with them every year, but it's kind of a moot point because the 200% of CMS cap is typically below what our direct negotiated contracts are with them. So that those reimbursements float with Medicare for most of those large, what we call DRG hospitals. However, on the non-1067 side, most of those are smaller hospitals. They're not DRG hospitals. They're not impacted by the 1067 legislation. So those reimbursements float as a percent of charges. So as those charge matches increases or they pass on higher rates, those are reflected in the unit costs. There are a few exception hospitals, the ones that are primarily out of state. They're large hospitals, but 1067 doesn't impact hospitals in Washington or Idaho. And Sky Lakes is an example of a larger hospital that's not where 1067 doesn't apply to them specifically. So they are on a fixed contract. We negotiate with them every year, but they are not susceptible to 1067. And then for non-hospital contracts, it's really just a mix of fixed contracts and automatically renewing. Again, most of the larger clinics, health systems that are non-hospitals, we do negotiate with them every year. You can go to the next slide. So I want to talk about methodology for how we reimburse our providers under our model, a PPO model, and the different types of contracts. So again, starting with the hospitals that are where 1067 applies, reimbursement changes are driven by the CMS rates. And that accounts for about 28% of OEB's medical spend. So that's non-pharmacy spend. So if you think about it, all the healthcare costs that flow through OEB, about 28%, not including pharmacy, are accounted for under Senate Bill 1067. And that's something that has actually been decreasing over time because the non-1067 reimbursements tend to go up a little bit faster than those that are held to the 200% of CMS cap. And as I mentioned before, 2024 increases were a little bit higher than previous. And something to note is the CMS methodology, particularly on the inpatient side, is a pretty complex calculation. But things that come into account are things such as the wage index, and that was particularly high in Southern Oregon, which drove some of those inpatient costs for 1067 hospitals in the southern part of the state. And then for those hospitals that are not subject to 1067, as I mentioned before, they're primarily percent of billed charges. They make up about 27% of spend. So they're roughly equivalent to those hospitals that are 1067. There's quite a bit more of those hospitals, but they're smaller in size. But overall, the spend is very similar. And what we've seen with those charge master increases over the last couple of years is they've averaged between 5.5% and 6.5%. So that's the unit cost increase that we're seeing. This is not including any of the increased coding intensity that was talked about earlier. I'll talk about that separately, but just on a unit cost basis, we've seen relatively high increases, at least above 3.4%, based on how they're passing through their bill charges. And those increases that they make to their charge masters really occur throughout the year, but most of those happen on 7/1 or July 1st. And typically those that happen on July 1st are higher than the average increases for those non-1067 hospitals throughout the year. And that tends to match some of the increasing trends that Kirsten showed in some of her slides earlier. And then the balance, about 45% of the non-pharmacy costs for MOTA and OEB are for non-hospital services, include a number of different professional provider types. And those are a mix of both those that are tied to CMS fee schedules. The ones that are tied to CMS fee schedules are typically renewed on January 1st, but there are other providers that are spread throughout the year. Okay, you can go to the next slide. So that was just some background, and I wanted to talk specifically from MOTA's perspective, how we do hold our providers accountable, particularly in an environment that was talked about earlier, where we're seeing some larger increases on the provider billing intensity. So what that really requires is what we call targeted reviews. So we are monitoring the trends that we're seeing, and we have two teams in particular at MOTA. There's a claims audit team and a fraud, waste, and abuse team. And I don't want to alarm people that there's any fraud, waste, or abuse going on, but we do have these teams, most carriers do, that are monitoring claims constantly and looking for anything that looks out of the usual. And what we have in place is contract language that helps us address anything that's out of alignment. So if there's any what we call egregious charge master increases, we have built into our contracts limits to how much our non-1067 hospitals can increase their charge masters annually. So if we see anything that's above what our limitations are, we will address that with the providers. And also, we do have language that if we see a billing intensity that's, say, 2% above what we've seen in previous year, we can address that with the hospitals as well. So there is some limitations or some protections on the billing intensity too that's built into our contracts. And then we also have protections when there is new technology that was referred to earlier, that when that's brought on board, that's the price for that new technology is not unreasonable. So we have the ability to review that with our specific providers to make sure that's reasonable. The way that we go about the corrections, it's a process. So if we find something that's out of alignment, we have to present those findings to the providers and to validate that what we're seeing is correct. Are we interpreting this correctly? So it's easy for us to sit inside MOTA and say, this seems out of alignment, but we have to have that discussion with our providers to make sure we're interpreting that data correctly and really understand what's going on. Have they implemented new software? Was it intentional or unintentional? Getting to the points that were made earlier in this presentation, is it a reflection of the acuity of the patient mix that they're seeing, or is it something that's changing on the provider's end? And are they doing that on purpose? Maybe they're trying to capture more codes because we're also putting pressure on them to make sure that we're getting quality outcomes, and that's driven through diagnosis codes and making sure we're capturing their services. So there's a lot that's going on with our providers, and we want to make sure that we understand what's happening. And then if we do see something that's out of alignment, we can take care of that through corrective action. And we have, if it's material and supported by the data that we see, and that can be done either immediately or at renewal with this providers. Something else that I think is relevant to this conversation, and I think it's something that Bill brought up earlier with maybe I'd call it something of an arms race with AI, where we're seeing new systems come in place. We also have systems at MODA, primarily through our claims editing software, that's catching changes that may not be allowable from a billing practice. So that's constantly being done on our side and probably being done on the provider side as well. So that allows us to catch changes that may be emerging that we don't think are warranted. And then there's also policy language that we have at MODA to make sure that billing is being done appropriately. An example of that is we review every emergency room visit and how it's coded to make sure that the diagnosis codes that are associated with that visit support how the level that those codes are being billed, or those visits are being billed. So those are the kinds of policies that we have in place and the edits to try to stay on top of this. Next slide, please. I wanted to spend some more time on the provider side and particular mitigation strategies that we have in place. So as I mentioned, for most of our largest providers, we do renew annually. And we look at what we agreed to with the provider in the prior contract year to see if that came to fruition. And if we see increases in unit costs that were not in alignment with what we expected when we initially negotiated the contract, we will build that into the future negotiation. So we're constantly ensuring that what we intended with that renewal is coming to pass with the actual claims that come through. We also look at what we call outlier contracts. So if you think about it, we have over nearly 7,000 provider entities that we contract with in Oregon alone. And that makes up nearly 20,000 providers total, or service providers. So what we're looking at is all of those contracts that we're negotiating, and we put those on a percent of CMS, which is similar to if you've ever seen the level of payment report that Mercer does. Everything's billed to a percentage or equated to a percent of CMS. And we look at particular contracts that may appear to be outliers in the total volume of contracts that we hold. And then we compare that to our other contracts. And it may be that a particular type of provider across the board has a higher reimbursement. That's just the way that is for a particular specialty type for MODA, or it could be a geographic distinction where there's few providers in a certain area that can command maybe a higher price. So we compare that to our other contracts, and also we compare that to the market. And the way we get market data, there's more transparency data that's available across the board. And then there's also what we call coordination of benefit claims, where we can see how those providers are being reimbursed by our competitors. So we look very closely at anything that appears to be an outlier, and we do that on a quarterly basis. And then we find opportunities for renegotiation. So that's one aspect. And then on the non-1067 hospitals that are primarily reimbursed on a percent of charges, those are definitely the ones that are subject to the inflationary pressures that we've talked about earlier. And as I mentioned, also, we are constantly monitoring any charge master increases. And when we have the limitations in place, we make sure those are strictly enforced. But in addition to that is we're not satisfied with that. And we do look for some of the top hospital systems and identify those as opportunities for renegotiation if we feel like those are out of alignment. One other thing that's not as pleasant to talk about is the potential for termination of contracts in those rare cases. And maybe some of you have heard more public disputes by some carriers and provider systems. We're a little quieter about that typically at MODA, but there are cases where we are not satisfied with the negotiation. The providers would come to an impasse, And we have to consider whether we have to actually allow that contract to be terminated. And it's a rare case, but it is leverage that we have and we do use in some limited certain circumstances. But there's one thing that we have to be very conscious of is that we do have access standards that we have to meet for what we call our insured business, and OEB does fall under those requirements. So it's not as easily said as done if we're limiting access. And of course, as I think Kirsten mentioned earlier, creating access for OEB is very important. So we don't want to do anything and be too cavalier about a contract termination. And then lastly, I think we have a real opportunity, and I know Garner was mentioned earlier, it's just starting off, but one of the opportunities I think that we have with Garner is once we get this up and running and we see the providers are not listed as a top provider, I think that's going to get providers' attention. And Garner's been really good about working with us and Mercer to say, well, we'll have conversations with those providers and explain to them why they're not a top provider. And we think that that's a real opportunity to either increase the quality or the unit cost to help them see that this is a real important tool to be listed as a top Garner provider and help us with our negotiations on a unit cost basis. I'm going to pause for a moment. I feel like I've been talking for a while. I want to see if anybody has questions so far, or you could say them to the end. Okay, I'll keep going then. Oh, Rick, please.
I'm sorry, just one quick question. The number of providers that are on the preferred provider list, has that gone up or down or stayed the same in recent years?
Okay, so I'll take a stab at it. Maybe Kirsten, you can help me if I don't have this right. So when I say preferred, well, Rick, are you referring to the top providers shown through the Garner app?
I'm talking about the preferred providers that get the higher reimbursement rates for an employee on the insurance, whether it's Garner or not.
Okay, well, maybe I'll
And I
start.
have to admit that I'm not totally familiar with Garner. I'm a new board member.
Oh, no
Greg, I
problem.
think Georgianne put the right thing in the chat, which is what I was going to say also. I think Rick is asking about, let's say, the size of your CCM network or your PCP 360 size.
Okay. Well, the PCP 360, those providers are primarily primary care providers that are PCPCH certified. And I think that has remained relatively constant over the last few years. I don't know that there's many additional primary care providers that have gotten that certification. I can say that generally our network we're constantly adding to our network. Again, that was part of our motivation to have more access available, and in particular in the behavioral health space. We've added a lot of providers. I wouldn't necessarily say they are preferred, they're just our network providers. We don't necessarily make a distinction there except for these PCPCH or PCP 360 providers.
Except for the CCM tier.
Yes, on the CCM tier.
Thank you.
Yeah, hope that helped. Okay, why don't we go to the next slide?
And Craig, Bill is wanting to know in the chat if you've seen a trend towards out-of-network providers leaving the network.
Not an overall trend. No, I think our network's staying strong and it's been growing. So we've not seen that. All right, I'm going to switch gears a little bit. And what Kirsten mentioned earlier, one of the strategies, and I'll talk about this as well, is to reduce the number of services as we keep people healthier. But given that we have a high number of services that are being sought by our members, and we want them to seek members, I wanted to talk about how we ensure that those services are of the highest value, both from a quality and a cost perspective. So topping the list here, we did implement Garner with this latest renewal, where we have it now. We talked a little bit earlier about the percentage of people who are accessing Garner. But it's the goal of this is to, within the MODA network, the Connexus network, Garner identifies what they call top providers who deliver what they're saying is on average 27% savings per episode of care. So it's not just a unit cost basis where they identify top providers, but they're looking at their total, what they call episode of care or total cost of care, to make sure that those providers are referring appropriately and delivering the appropriate follow-up care and managing patients. So that's how they get moved to be designated as a top provider. And one of our strategies, and I don't want to get ahead of the Mercer team to talk about where we'll end up, but we do know that with Garner in place, there are enhancements that we can make for the upcoming renewal that we think will help close the gap for a 10-1 of 27, or 26 rather. Another thing that we are happy about, and I think this gets into a question about capitation versus fee for service. We do have value-based payments in place. One in particular is our total cost of care incentive that we have with our PCP 360 providers. Those are the providers that when members choose the CCM tier, they go to PCP 360 provider. And we have a contractual arrangement with them that rewards those providers if they manage their attributed populations to the 3.4% cost growth target. So they're very conscious from a reimbursement perspective that they have their attributed membership. And what that means is part of the OEB population, people choose their primary care provider, and all of these members that are attributed to those primary care providers we look at them as a population and work with those providers to help them manage to the cost growth target program. The eviCore side of care program was also introduced with this renewal. It's a new program that is focused primarily on musculoskeletal and advanced imaging. Those are particular services that have a large variance in reimbursement. If you get an MRI at one location versus another, the cost can vary quite a bit. So this side of care program helps catch those procedures early on when the provider is actually getting the prior authorization to try to direct those to a lower cost setting that's clinically appropriate. So we see that going into effect now. We're anticipating that'll help. And then lastly, with our MODA 360 program that's been in place, our care advocacy piece of that is trying to catch members early on in their disease states to make sure that they are getting highly coordinated, well-coordinated care to get people to the right providers at the right time to avoid their conditions becoming too expensive. So those are some of the strategies. A lot of that is around for the services that we anticipate will continue, trying to get them directed to the most appropriate clinical setting and cost-effective place. Go to the next slide. So I'm going to switch gears entirely. This gets into some of the cost drivers that are not related to provider reimbursement specifically. And what I want to start here, we had a presentation earlier about high cost medications, and what I wanted to focus on here in particular is what we call high cost therapeutics. And those are not part of the pharmacy benefit, but they are considered part of the medical cost, but they are pharmaceutical procedures for the most part, and they are provided at a hospital or a physician or by an infusion provider specifically. And what we saw with this last plan year was about a 27% increase on a per member per month basis. So similar to what was talked about earlier about innovation and increasing costs for pharmaceutical procedures, we're seeing this also on the high cost therapeutic injections as well. And that's largely influenced by the site that the treatment is provided. So a similar treatment that's provided in a doctor's office versus an outpatient hospital setting can be quite a bit less. So this gets into, again, trying to drive people to the right setting to get these services. But I wanted to show in these two tables what's happening with some particular procedures or therapies. And the way that the therapies are listed is when you're getting one of these injections, there's something called a J code that gets billed, and they're billed by units. And for these 4 J codes that I list here, I wanted to show what was the cost to OEB during the 2022-2023 plan year, which is 2 years ago, versus what we saw this last plan year, just to show the inflation that's happening in these particular therapies. And I won't go through each of these, but what you can see across the board is we've seen, roughly about a $3 million increase just for these, or actually closer to a $4 million increase just for these 4 therapies. And a lot of that is driven by the members that are receiving these therapies and the units that are being charged for this therapy. So we're looking pretty closely at what's driving that, but I think that's, again, a reflection of what's happening with the underlying population and some of the need for these services. So it's definitely an inflationary factor. And then the bottom table, again, related to therapeutic injections. These are new therapies that we've seen, J codes that were not in existence prior to the last plan year. And these are all for just one member each of these therapies. And some of them are quite expensive. So between these 3, it's about a $3.3 million cost increase for therapies that were in place before. Now, some of these are probably very rare conditions that just aren't common, and maybe we're just seeing these because they only occur from time to time. But again, related back to what we were shown earlier about the innovations in pharmacy, we're seeing it on the high-cost therapeutic injections as well in our own data, and that's driving some of our increase. You can go to the next slide. Sticking with the theme of what's happening with the acuity of the population within OEB, what we're seeing is an increase of cancer and the costs of the of cancer-related diagnoses. And what I wanted to show here is some of the top cancer diagnoses. This isn't all cancer, but these are some of the top diagnoses. And the table shows the per member per month costs in the population. And what's kind of interesting about what we're seeing here is that pre-pandemic, that's the first column, 2018, 2019, the overall per member per month costs were $11.73, close to $12. And then that really dropped off for these 5 cancer diagnoses as we got into the pandemic and then the first few years afterwards. And then this last year, there's a very high increase, about I think it was close to a 40% increase in the per member per month cost for these particular cancers. And that's both a reflection of the number of people who have had these diagnoses and also the cost of the chemotherapy that they're receiving. Some of that is related to the high cost therapeutics I mentioned in the prior slide, and also some of the high cost medications that were spoken about earlier in the presentation, and also room and board costs. So not only these people, we're seeing some of these diagnoses coming back, but we're also seeing the intensity increase in the last plan year. And that's driving some of the cost increase in the renewal. Okay, you can go to the next slide. I'm going to finish with a couple slides related to what we call risk scores. So risk scores are a way to show the underlying disease burden of the population. And so it's really kind of the health of the population, if you will. And what it does is for each of the OEB members, we analyze the claims and the diagnoses on those claims. And the risk score is developed from the diagnosis on the claims and the expected cost from the diagnosis. So this is not related to direct costs, but the expected costs based on the diagnoses of the membership. And something that's really interesting looking at this compared to what Kirsten presented earlier is the pattern, the increase in average risk score for the population directly mirrors what we saw with the number of people who are accessing care within the OEB population, this trend line. So if you think about it, as more people are accessing care, which we were seeing earlier, the more people will have diagnoses. So on a population basis, we're seeing these risk scores increase. And these are risk scores that are what we call excess risk scores. They are not including demographic changes within the population. So we've definitely seen the acuity of the population increase as people access more care, and the risk scores are reflected here. But keep in mind, the risk scores are a reflection of the diagnoses that are on the claims that we're receiving, so that there is some interaction between the increased number of diagnoses that was referred to earlier and the potential impact on what we're seeing on the risk scores. Enrique, you have a question?
Yeah, so I'm listening carefully, and I'm hearing that this predictions long term of disease and medicine and cancer and the demographics, but I guess I don't know if it's the right question, but I think it is. So last month in the media and social media, we saw like 4 scientific breakthroughs, right? Cancer, the discoveries, and Alzheimer's, and better therapies and preventative outcomes. So the question is this calculation, I guess what I'm trying to say, in academia, you can predict 10 to 15 years, somewhat of a mean value of predictors of breakthroughs within the medicine field, just like in IT, everybody says we're 10 years out in AI, or, so I was wondering if that is actually into this risk and demo presentation, because if I'm assuming that all the discoveries are being made right now in the labs and going through trials, this would cause the medicine to go down after the testing is done. So I was just wondering if that would decrease the cost of medicine and care.
So I'm not sure how that relates to risk scores, but is your question more related to breakthroughs in medicine and how that could affect the cost of care?
Yeah, because I see that higher disease burden. So means we have less disease, or the cure for disease is going to be a lot shorter or better than what currently have now. So therefore, in 20 years from now, when I'm 50, 65, the cost is not going to be the same as is predicted. Does that make sense?
Yeah, I'm not.
You're wondering, I think Enrique is wondering, Enrique, let me know if I'm tracking. I think so. It's a good question. I think the essence of your question is, at some point, these breakthrough therapies should pay off in better health. Is that?
Yeah.
Yeah.
Exactly. Because we have new discoveries of medicine, right? So this cost should be lowered. Does that take into account here?
Well, yeah, and what's shown on this slide is simply the diagnoses that are showing up in the claims. It's not really a prediction of future costs.
Okay.
Yeah, and I think what's happening here too, Kirsten might have mentioned it too, is when there were access issues earlier, the disease burden of the population may not actually be increasing like this. It may be that people weren't getting in to the provider, so we weren't seeing it in our data. So it can be a combination of both people not getting into the providers, and then now that they are, we're capturing these claims and showing that, and it's being reflected in the risk. but it's what what we want to do, and I think this was alluded to earlier, catch diseases as early as possible. And something that's, I think, a concern of everybody post-pandemic is that during the pandemic, people were not getting in to get their preventive services. And was there some sort of missed diagnoses on things that got more costly because they weren't caught earlier? So that may be factoring into some of this as well. But yeah, this doesn't necessarily help with the prediction in the future from some of the breakthroughs that we're hoping to see.
Thanks, Greg. Appreciate that. Sorry, that's the wrong type of question for the presentation.
Enrique, I think so in Kaiser's presentation, which is going to be next, not to steal their thunder at all, but I think some of their chronic condition trend data will answer your question a little bit too.
Okay, thank you.
Good. All right, I have one more slide and then I'd be happy to take more questions. So this is a similar slide to the last one, but what this is showing is the monthly change in that risk score to give a more of a sense of when did we really see the risk scores change the most. And what's interesting about this slide is the peak or the biggest increase that we saw from month to month in our risk scores happened at the beginning of the prior plan year, which again is very similar to what we've seen with the cost increases or the allowed cost increases that Kirsten showed on her slide. So and I think that discussion was very good about what we need to understand here is that driven by the people who have health conditions that are coming in and they're more acute in nature. So they needed higher intensity services, or was some of that driven also by how the providers coded those services. So that's what we need to tease apart, but it is directly related. So a lot of the question around the increased cost per service was, well, is it unit cost related or is it intensity related? And I think this slide really shows that we were seeing many more diagnoses attributed to the members that were going in at the beginning of the last plan year, which were driving up the cost per service. Not just the unit cost for those services, but they were higher intensity services. So that is my last slide. I guess maybe I'll say one more comment before I open up questions. But again, I think and it kind of gets back to Enrique, to your question too, is what we want to do is try to keep members from going into the health system. So it's, catching people early with an emphasis on wellness and prevention is something that we're striving to do as well. And I think that'll help with some of the longer term trends as we go forward in the future. So thank you. Happy to take questions.
Am I disconnected or is nobody talking?
Oh, go ahead, Bill. You have a question?
No, I didn't. I just thought I was silent for a while.
Oh.
I was like, oh.
No, I was
Okay,
waiting for.
so you can still hear me.
Yes, I was wondering if anyone has any questions for Craig and the Moda team. Otherwise, we can move to the next presentation.
Thank you.
All right, great. It looks like you did great. No questions. So see you soon.
Okay,
Kaiser.
friends, we're up. So for those of you I haven't met, I'm Dr. Mark Mueller. I'm the OEBB Medical Director on the Kaiser side, and I am accompanied by a great colleague today, Paul Schultz. He's our Executive Director of Actuarial Services, and we are happy to spend just a little bit of time with you today. So go ahead and advance, Rose. We were asked to talk a little bit about our rating trend and a little bit about provider dynamics. You're going to hear Paul kind of touch based on those, but it'll be a lot of recurring themes. So hopefully we can kind of catch up timing and just hit some of the highlights that you've already heard. And then I'm going to switch gear to a little bit of innovation for pharmacy and cost control within the Kaiser model, and then kind of go over that chronic condition prevalence discussion that we were having there. Go ahead and advance the slide, and I will turn it over to Paul to begin.
Thank you, Dr. Mueller. Good afternoon, everyone. Very pleased to have the privilege of speaking with you this afternoon. If you will advance one more slide, please. So much of my planned commentary was covered by Kirsten in her excellent presentation, but there are a few items that I will try to emphasize for you. The first has to do with timing. So the chart that you see in front of you has two lines on it. The darker line represents market trend. This is similar to something that Kirsten presented earlier. We use a different data source, and so the numbers on the page will be very slightly different, but generally quite consistent with what she presented earlier. The red line is the Kaiser Permanente average increase. Now, this is across all of Kaiser Permanente. It's not OEB specific, but we wanted to call out where the market's been versus where Kaiser Permanente has been. And obviously, what jumps off the page is that very large spike in 2024. So I want to talk a little bit about what in the world is going on there. So like other providers and health systems, Kaiser Permanente is not immune to the cost pressures coming out of COVID, such as inflation, increased demand and increased morbidity, leading to a greater demand on services, higher staffing costs due to an increased reliance on temporary staff, such as traveling nurses. So all of these things hit us as well, just as they did other providers. The difference is that with Kaiser Permanente's model of integrated care and coverage, all of those cost pressures flow directly into our budgets, into our premiums, into our fee schedule in real time. That's different from a traditional carrier. A traditional carrier will feel those pressures as they renegotiate with different providers and health systems. So it's a more gradual impact. So what we can see is that all those cost pressures really hit us in 2024, where Kaiser Permanente experienced higher increases. That was true for OEB just as it was nationally for the bulk of our customers. But now that we've negotiated that peak and we're on the other side of it, we've now returned to seeing increases that are below the market for Kaiser Permanente. If you'll please turn to the next slide. You'll notice that among the cost pressures that we list here, revenue optimization is not among those. Kaiser Permanente does use ambient listening technology to accurately capture what is covered during a provider visit. But again, due to our integrated care and coverage model, there is no directive to bill higher that's associated with that. Rather, our focus is to achieve value-based outcomes that improve health, thereby lowering costs. And with that, I'll hand the microphone back to Dr. Mueller, who will highlight ways that KP is working to mitigate healthcare cost trends.
Great, thanks. Go ahead and advance, Rose. So when we talk about medication-related services or pharmaceutical affordability, I think it's good to start from a place of a reminder that KP Northwest is just one piece of a much bigger national model. So our 12.8 million members nationwide give us a little bit of a bargaining chip when we purchase medications. And also the ability to avoid pharmacy benefit managers gives us some built-in ways to start off with saving some costs. Our 26 pharmacy sites in the Northwest are just a small part of the full nationwide picture, but innovations that happen in Southern California or Colorado can easily be put into the Northwest system as well. And what we have written there are 8,000 pharmacy-related member interactions daily. Those can be anything from filling a drug, tracking a drug interaction for a patient, but also measuring adherence, which is so important to what we're going to talk about for chronic condition management. Next slide. I could probably talk for a very long time about the value that I see of practicing within an integrated pharmacy system as a doc, but I'll start on the lower right-hand side, that strategic purchasing of medications. Once that's done, those medications that we know we're going to use are put into our evidence-based protocols. And so what I mean by that is, if you are an internist with 30 years experience, or if you are a brand new resident out of training who is just going to start paneling, and you have a patient in front of you with diverticulitis, you might say, I wonder what the current data is. You can put that into our integrated EHR, and it will tell you that our first line is Augmentin, followed by Bactrim and Flagyl. So it's not restrictive. It's just telling you this is where the current evidence and value collide, and you might want to consider doing this. Once those medications are dispensed to a patient by our pharmacists integrated into the same clinic, you are educated by our pharmacists. And then depending on the drug you're being given, say I use something like losartan to manage my patient's blood pressure, one of the big things is the patient taking it, right? Are they adhering to the medication? So twice in the last week, this came up to me that it really helps me develop conversation with the patient where I can gently say, it looks like you're not filling your metformin as indicated twice daily. And it's not meant to be admonishing to the patient. It's more about a creative strategy. Tell me what's not working. Perhaps we need to change our plan to get you to your goals. Then we track outcomes, right? And so we know if A1Cs are coming in line, if lipids are coming down, and as we see need to change or evidence changes, we then go back to our formulary and say, what needs to change again? And for instance, I think right now that's evident in how GLP-1s have gone from 4th line to 3rd line to 2nd line for us for diabetics. And then when we make a change like that, we go back into strategic purchasing and start the cycle again. But it really like goes home to say, if you are being treated by a doctor in Beaverton or you're seeing me down in Eugene, you're probably going to get a similar experience in the kinds of care we're recommending. Next slide, please. This has really been touched on at least a couple times by Kirsten and Nathan so well, but yes, I do think biosimilars are one huge way that we can control costs. Keep in mind, this is not an inferior treatment, right? These are FDA reviewed treatments that are 100% as effective. They hit the same end receptor or the same spot in the inflammation cascade cycle that causes you to have ulcerative colitis or psoriasis. So when a drug comes on market that we can replace, like Amgevita for Humira back in 23, as Kirsten said, we were able to do that really 95% conversion on day 3. And that is because it has just dropped across all pharmacists, all clinicians to know this is the new way we're doing this. And you might say, what does that really look like for cost savings? In preparation for this presentation, I looked at 2025 pharmacy data spends for OEB, and Amgevita was a top 5 drug. So if you're replacing all those prescriptions with Humira, you can see how that suddenly adds up. We're doing the same for Stelara, as was mentioned, beginning in March 2025. And within the first month, we were able to convert about 98%. We're almost fully there with about a savings of estimated 14.2 million in the Northwest alone. So these things really add up. And while I think it's really important to focus on these big, expensive drugs, these happen for generics too in run-of-the-mill conditions. So when things become cheaper, we can quickly say, this is a great way where, again, evidence and value collide and how we're going to start treating patients. And we're all on the same page very quickly. Next slide. This has also been talked about, so I'll go a little bit quickly through it, but we do know that innovation means more cost. And when it comes to something like gene therapies, we have an emerging therapeutics strategy program built into Kaiser that says it's not necessarily condition A equals treatment X, but let's really take a good look at those clinical trials. Who actually benefited the most in those trials? What were the pros and cons of the treatment? How do they compare to what we have in current existing therapies? And what was the burden for the patient? In certain cases, right, I leave an example there, a one-time cost of Hemgenix, which is a gene therapy to treat hemophilia B, a clotting disorder, can be 3.5 million. That is jaw-dropping, right? But when you think about, in certain cases, the alternative to it, We may have to give somebody a factor 9 infusion multiple times. They may have several hospitalizations. And when you add up all those treatments within a 5-year time period, you can exceed what that initial cost was. So it's crucial that we have a way to really look at these therapies and say, when do they really need to apply? What type of patient may benefit from existing therapies we have? Next slide. I'm going to switch to chronic care prevalence and how we manage this. So I've heard, and kind of being the background of these meetings, over and over that utilization has gone up coming out of the pandemic. While I am medical director on these accounts, really a lion's share of my FTE is a primary care doctor. So I bring that perspective to you that it's very true. These are not just numbers that go up on a graph in terms of like people coming out of the woodworks from the pandemic. I am an eternal optimist that we're cresting a little bit, but it's not just as simple as my blood pressure has been a little high and I need to get back on my metoprolol. I have patients that say, I ignored my left hip that needed to be done and I'm back and it's so much worse. And I've been sedentary for 2 years. And that meant I've gained 30 pounds and my blood sugar is up and I may be showing early signs of heart failure. So you can see that it's a lot of work to get them in, get adjustments to prescriptions, get them in the right counseling, get them lifestyle coaching, whatever they need to make them a proper surgical candidate so they can get optimized to really get better in the long run. When we talk about how we manage chronic care within Kaiser, the members at the center, and I'll start up at the top right on my screen, proactive. If I draw screening labs on you and you have an A1C of 6.2, that means you fall into a pre-diabetic range. And suddenly, yes, I know what to do about that as a clinician, but suddenly the EHR kind of develops a new take on itself. It says, hey, doc, are you aware that they are pre-diabetic? You may want to pay more attention to their blood pressure. How has it been? What is their cholesterol like? This is, again, being proactive, that double down on wellness and prevention that we talk about, right? So we start looking at those upstream right away. Comprehensive care means that you as a patient may want to do some online education. You may want to work with a lifestyle coach. You may want the focus of your work to be with me as your primary care doctor, but it also includes your specialty teams. When I say it's system-wide, it means that whatever your blood sugars are running or the prescription regimen that we have you on, the pharmacist knows it. God forbid you're in the hospital, but they know what you're on and how well or not well controlled you are. So everybody's speaking the same language when it comes to taking care of you. We are team-based but physician-led and data-driven. That's not just HEDIS data, but that is also saying, let's track medication. Are people using them correctly? How can we get them to improve adherence? I'll pause, Dr. Lara.
Just a quick question. So you just mentioned that actually the providers team, they're gonna kind of start on the same baseline. How do you apply health equity here specific, because each patient is gonna start at the same level. So I just wanna try to see how Kaiser Permanente kind of think about this and how we can integrate that. Thank you.
Yes, thank you for the question. I think I understand what you're asking. I do consider it equitable because every patient is going to be known to the system wide, right? No matter where they're starting from. And I'm going to show you a little bit of slides in a few minutes to talk about chronic care conditions and how we look at those in an equitable manner to make sure we're giving equitable care. So we can go to the next slide. These are 7 chronic conditions, and the message really has been that chronic condition prevalence is still going up, right? So in the green bar is OEB compared to the dark blue bar, our Kaiser Permanente regional average, and then the light blue bar is Kaiser Permanente industry average, so another account that may look similar to OEB around the country. And you can see in some of these conditions, let's look at diabetes, heart failure, hypertension, you are actually doing better than the regional average, but the number is still slowly climbing year to year. In some others, depression, asthma, obesity, you are at or above our regional average. And you may say, if you look at coronary artery disease, that's a win. Only 0.3% of OEB Kaiser Permanente members have this diagnosis. But I would say that 0.3% is a small number that can turn into a big number in terms of the cost of downstream care. If you're talking about hospitalizations, stents, or long-term care somehow. Questions on that, I'll pause. Okay, next slide. So to get to your question, Dr. Lar, it is really important that we look at this not only in prevalence, because we can't go through all 7 of those. I'm going to just drill down and look at diabetes for the next couple slides. But it is really important that we look at diabetes prevalence across gender, age group, race, ethnicity, language preference, and make sure we are offering equitable care. Here is OEB in the green bar compared to Kaiser Permanente regional average in the dark blue bar. And I told you on the previous slide that you are doing a little bit better in terms of prevalence. So you'll see the green bars are a little bit lower. But when we look across these, it is important to split the data this way. Most of the time, OEB green bar is lower, but is there a couple places among Black in race, ethnicity, or other language preference? Is there something about the prevalence in those categories that can cause us to look at the way we do things or address culturally things appropriately? Next slide. And as we drill down a little bit further into diabetes care, again, making sure we are giving equitable treatment, diabetes care in this case is defined as having an A1C less than 8%, so marginally good control of your blood sugar, being up to date on an eye exam, and having target blood pressure. So here again, we're looking at across how well are people doing split by gender, age group, race, ethnicity, language preference, and we are seeing that we're offering equitable care to the regional average across the market when we look at OEB data. Next slide. I thought to describe really how we bring somebody into chronic care management in our system, I would just kind of briefly tell a story about a patient. So a patient of mine, 48-year-old mom, she comes and says, I am so tired. I don't know if it's the world, my kids, perhaps I'm going through perimenopause. I don't know what it is. Part of our discussion, we decided to do some screening labs, and her A1C comes back at 7. So the first thing we're going to do for Carla is develop a customary care plan for her. Everything starts with diet and exercise, but maybe she doesn't have the time. Can we get her a health coach? Can we get her into some resources that make sense for her? I'm probably going to talk to her about metformin as an early medication with value added to reverse some of her insulin resistance. We're going to talk about who else might be a good team member for her, a nutritionist or a nurse care manager to help her with some diabetes education. It may happen that she gets busy with life. She may lose a follow-up visit here or there, but our EHR is working for us behind the scenes saying, you have not seen this patient that you just diagnosed. She goes on to a list of outreach. So our chronic care management team reaches out to her. She says, I was a little overloaded with the new diagnosis, but we get her back in. Depending on how much time has passed, I may have a clinical pharmacist manager help me with this, so they can work her up through the formulary a little bit faster, so that by the time she gets back to me, she's on Victoza as well. She's losing weight. And she comes back to her primary care doctor saying, I've made progress, rather than where have you been? Things are no different, right? So that is helpful to me and her in terms of working upstream. And then when she comes in for her eye exam, we remind her that just because she had a diagnosis of diabetes, that is not the only thing that defines her. And we're looking at bird's eye view that she also is due for a mammogram, and we get her scheduled right then and there. So sort of the way we look, getting people into care and how we decide who their most valuable team members are for them. Next slide. Finally, I want to focus on a little bit of like good data, again, going back to that wellness and prevention. So I'm proud that we ask about exercise as a 5th vital sign, right? That is so key when we're talking about obesity, hypertension, blood sugar. What are some things that are potentially going well? When we look at OEB's results, I have this divided into 3 categories. Members that are active, that means they get 150 minutes of recommended exercise a week. Some activity, 30 to 149 minutes, or they're living more sedentary, less than 30 minutes. And you can see year over year, our members are getting more active in both the active and some activity categories and becoming less sedentary. So working upstream, focusing on things we can do before people are chronically ill. It unfortunately means 60% of them don't meet the activity requirement, which results to about 8,400 members. And then when we extrapolate to extra medical costs related to inactivity, you can start to see how not putting your efforts here add up. Okay, last slide. I just wanted to hit home one more time about the way that I think one of our strengths is that we can integrate things so quickly when new emerging evidence happens. So when that new biosimilar happens, we can quickly update all of our clinics, all of our pharmacies, all of our operational infusion teams on the new standard of care, what we're doing. Going back to that example of diverticulitis, if something changes, I try to keep up on all that as a good doctor, but sometimes you go into an office, you pull it up and go, wow, I didn't realize that became new recommended primary therapy. And right next to it will say gastroenterology and clinical pharmacy reviewed this as of this date, and this is the new standard for value-based care. And then I still have the choice if I'm going with that or something else. And then finally, we embed these changes quickly to make sure we know how we're going to take care of our patients with chronic conditions. So if I have a patient who has uncontrolled hypertension or diabetes, I have a one-stop shop where I can get them referred to other team members that are just going to be helping us along the way. Clinical pharmacists, nurse educators. And so we all are aware of how that works, and we can quickly get it going for the patient. Thanks. I think that's all I have. I'm sure Paul or I are happy to take questions if you have any.
All right. Any questions for the Kaiser team? Otherwise, we can stretch and go on a walk so we can have less healthcare risk based on the last presentation, the little PowerPoint. Got to do more walking and less sitting. All right, we're almost towards the end of our agenda. Glenn, I'm sorry, Kristen, do you want to talk about the renewal next steps?
Yeah, thanks, Enrique. I'm going to shorten this a little bit because I want to make sure that John has time to give an update on the standard, and then Glenn also has an update for you. So I'll talk about approaching this challenge.
This one is just clarifying.
Oh, sorry, I was confused for a minute. We'll look at this slide, approaching this challenge together, and then we'll look at the next slide, preview of renewal strategies, and then I'll hand it over to John. This is a balanced framework that we developed with you board now, I think 3 years ago. And it prioritizes in order the 4 levers that we have for achieving 3.4%. Our first lever this year, prior years, and always is to negotiate with your carrier partners for the most high value, lowest cost plan options for you. The second one is efficiencies, which in general means connecting members with the highest value, lowest cost care, which sometimes means in certain places compared to others and with certain providers compared to others. Subsidy is something we have previously been pretty judicious with because it has downstream consequences. We may have a different discussion around subsidy with you this year, but it remains in our arsenal. And then offsets is our last priority. Similarly, in prior years, this year, and always, we will always endeavor to make benefit changes last. We strive to preserve the benefits for your OEB members as much as possible. On the next slide, I just want to give you a high-level preview of some of the ideas that we've been working on with Kaiser and Moda behind the scenes. You'll see the details on these ideas in April. So negotiation has been ongoing and will continue to happen behind the scenes. In terms of efficiency with Moda, we're looking at alternative provider networks. Alternative provider networks are a theme in the commercial market and have been gaining traction as costs have been increasing and employers look for ways to reduce cost without reducing benefits. Alternative provider reimbursement arrangements, we mentioned this. Potentially this is a 2027 strategy, but we're definitely looking at it. Additional pharmacy utilization management opportunities, because you saw in many slides today illustrated the cost pressures from pharmacy. Clinical program optimization means that we're only paying and supporting programs that are delivering value for your members. Subsidization. So OEB has $97.3 million total in subsidy. This amount is combined between the OEB Stabilization Fund and the Rate Stabilization Reserve RSR. These funds can be used to help offset the rate. Any amount that we use this year has a downstream negative impact on the following year. However, it is definitely going to be part of our conversation with you this year. Obviously, if our gap is $110 million, around double what we've had the prior years, stabilization subsidy would be really helpful in helping to make that a more manageable amount for your members. Plan design changes and portfolio realignment have to do with which plans are offered and how much do members pay for them. We have currently rates that vary by tier, employee, spouse, child, family, or composite rates. We have rates for plans 1 through 7. So there's lots of different rates, and not everybody is paying a premium rate that supports their level of claims. And so that's something that we'll bring back to talk to you about as well. I just want to make sure before I wrap up and pass it to John, I'm going to scroll the rest of my slides here. I think you can just take the rest of these back with you. They just provide a little bit more information about some of the things that I summarized, but I don't need to cover those again. Okay, so with that, I'm going to pass it over, John, to give a standard update.
Yeah, so yeah, we can scroll through to the standard update. Great. So also, I just want to acknowledge the board's engagement with this very technical material this afternoon. Really appreciate the questions and such. So now something pretty different for just one quick slide here. So we're coming off of a multi-year rate guarantee with the standard. So we do have renewals with the standard this year. And as a reminder, the standard provides life, and there are various varieties of life. There's employer paid, and then there's optional life for employee and spouse and dependents as well. And then in terms of disability, there's short-term disability, long-term disability. And as you might remember, there was major changes in the Oregon market a couple of years ago in 2023 and September 3rd. There was the implementation of paid leave in Oregon in terms of the benefit. So that's really changed things around the use of the STD benefit, the short-term disability. So just some context setting as we go through these changes. The overall impact is a 4.4% decrease across both the life and the disability plans that I just mentioned. The majority of the rates were there were no changes, and then we're just highlighting the exceptions here. So the optional life rate is decreasing 15%. The employee paid LTD is decreasing 10%, and the employee paid short-term disability is decreasing 30%. So that gives you an update. And these are really just preliminary. We've been working with the standard. They provided us, with a lot of data backing, the rationale behind these increases. And so we're going through that data, and we'll be going through applying some of that, the balanced approach that Kirsten was just going through. So we'll be going through negotiations over the next month, on where we think there's a need to do so. So I think that covers the standard update. So unless there are any questions, again, wanted to pause for those. Then let's go to the next slide, please. So again, this is really just previewing next month. And so next month is really when we have to kind of roll up our sleeves and apply that balanced approach that Kirsten was just alluding to. So we'll be coming, with a variety of options and their potential to yield a certain amount of savings. And then we'll be going through those with the board, and then, thinking through how those might be applied, the order in which they might be applied, and which ones that you would want to apply. So again, and then also, in the interim, we're also continuing to evaluate and negotiate. I think it's important to understand that, we've been working on the renewals really since January, or even a little bit earlier. So, to come up with solutions, because we obviously had some inkling that it was going to be a challenging year. So we've been working for some months already to come with, options for the board. and those will be presented in April. And then, May, looking to get those decisions finalized. Any questions? Again, thank you for your attention, as we went through a lot of technical material today. Hopefully there was a helpful background.
All right, any questions for Team Mercer? All right, we are towards our legislative update in Seattle, so take it away.
Thank you, Enrique. I'll just wait for Rose to pull up the attachment I sent out, but I'm going to provide for today the legislative and CIAO updates. Just for the legislative update, I'll start off. We're getting near the tail end of the legislative session. It actually will end on March 8th, if not a little bit earlier. It was a short session. It started on February 1st, so it was a very quick session, not as many bills as we've had in the past. We had a total of probably about 50 bills. They really were broken down into 3 different areas. Priority 1 bills, those would be bills that we feel we're going to have just they wanted OEBB say to do a new program. Priority 2 would be many times, these are benefit bills. These are bills where they would increase our premiums because it would increase our overall costs. And then priority 3 are bills that say may change our benefits in some way or our systems in some way, but don't have any fiscal impact. The majority of bills actually were, we classified kind of priority 4 where we just watch, but really end up most of the time having no impact on OEB or PEB. For the priority 2 bills, I'm not going to go into all the details here, but I would just Rose, if you could, I believe, go to the next slide. Yeah, for 1558A, this is a kind of a repeat of a bill that's been, I think this is about the 4th version, I believe. It is a bill to require that all carriers cover IVF as well as other infertility practices. But it also would have required that this coverage be done in a manner where you don't have literally any type of cost sharing or limitation, say on the amount of services that you get that aren't used by other practices. And right now, both PEB and OEB actually do have a benefit cap or kind of a benefit management on that. The bill is currently in Ways and Means. It does exempt PEB and OEB, so it really wouldn't have an impact on us, and it has not been scheduled for a hearing, which is really kind of a sign that it's not going to be moving anywhere. If you can go to the next page, Rose. The priority 3 bills, we had a kind of a wide variety. We had one big omnibus bill, 4070, which would have, it really was like 6 bills in one, and it addressed a number of different benefit topics. But none of those would have had it really kind of much impact on PEB and OEB. That was the primary one. The rest of them are dead, or some have passed. But if you have any specific questions on any of the bills listed here or any others, you can just ask me now, or send me an email, and I can give you kind of an update on it. I actually work with a team of 4 other analysts who really do a great job, and we analyze the bills both for what is it's going to be its impact on PEB and OEB, say from a programmatic or a policy standpoint, as well as a fiscal standpoint. This information then gets to the legislators either through OHA leadership or through what's called the Legislative Fiscal Office. Again, this was the short session. Next year will be a longer session, which is going to last from February through usually till about mid-June. Were there any questions in regards to the session or just the legislative process overall or the bills? Okay. Well, then I'll move on to the CIAO update. CIAO met today. We had 2 items on our agenda. The first one was, it was really kind of the final element of our vendor management report on our type 2 diabetes programs, which actually included weight management, pre-diabetes, and then diabetes management. We had last month, we had the actual data on this, and Mercer, as part of this project, had done a really comprehensive job of looking at various aspects of how our vendors are performing. From clinical outcomes to health equity to engagement, how they really have performed. This month, what we looked at were really, they again came back with kind of an overview summary, but also looking at what is the landscape out there, what are the best practices, with some really recommendations for CIAO to consider. The recommendations, one came around Weight Watchers, which has the highest engagement and a very high member satisfaction, but has had very mixed results on, actually kind of not as good results as some of the other programs in regards to clinical outcomes. So one of the things that, or what Mercer will be doing, is coming back in April with a recommendation for, moving this program into a really kind of a voluntary discount program. But again, they'll be coming back to the board in April for their final decision on that. The other recommendations had to do with where we would replace, right now we have 2 diabetes management programs, Livongo and Virta for the MOTA population. And these programs, Virta has really the highest results overall, while Livongo has seen really some of the poorest, with even people reversing in regards to their overall health on that. So their recommendation was to replace Livongo with Virta for the MOTA population. The MOTA Pre-D program, which goes for pre-diabetes, has worked well. The results have been good. And the recommendation is to look to expand this program for weight management and possibly diabetes management. But again, these recommendations will be coming back to the board in April for a final decision. CIAO approved of these recommendations for both OEB and PEB. But again, they'll be providing the final details in April. Sorry, I've been talking fast because I didn't have that much time. Are there any questions in regards to what CIAO was addressing? Oh, and I'm sorry, CIAO also was looking at the cardiovascular programs at the carriers. This was part of a program where Mercer, for our renewal, had been working with the carriers, getting information based on how their programs are working in regards to various steps from intervention to maintenance to just how they're performing overall. They worked with the carriers, got the information, and had looked at also what is the most optimum programs out there. What do you need for really optimum success with these programs? And what they presented to CIAO was that they wanted to do a research group similar to the other research groups that we do every year in August and September to do a kind of a deeper dive and then work out what are the metrics, what are the details of such of these programs. They felt that the carriers programs were good in regards to, but needed some, really looking at the various elements, the process elements, and just the elements of the programs based on this optimum standards that they had found for cardiovascular programs. So CIAO said yes, and there will be setting up that program that research group for August and September. Enrique?
Yeah, it's towards the end of your report. It's okay. You can keep going.
Okay.
Thank you.
So that is the two items that CIAO was looking at today as part of its meeting.
All right, Glenn. So I guess I can ask my question. Maybe it's not related to OEB, but it is related to OEB. It's related to healthcare. And you may be able to tell us what's going on. At the legislature, there's a bill that talks about a hospital at the coast in the rural area, and they're looking for funding to be able to sustain this hospital open. And I'm concerned that some of the proposals is that they want to get money from different parts of the budget, to maintain the hospital open. I was wondering, with your knowledge, what other budget items within the legislator or are legislators allowed to touch? For example, I don't know, a rainy fund or some sort of like specific allocation.
That bill wasn't looking at, say, using funding from, say, our stabilization fund, no, or PEB stabilization fund. It was more looking at ideas of how getting general fund money, for which we aren't a general fund agency.
Okay.
But I don't know exactly. I'd have to go back and look, where they ended up on that.
All right. Thank you, Glenn. Appreciate it. All right, members, any questions before the order we adjourn? Any questions or comments for the good of the order? Ali? Staff?
Rose, was there any public comment?
No public comment.
We'll be in touch with details about next month's in-person meeting, and looking forward to seeing everyone.
Bye, everybody. Thank you. Have a good day.
Thanks, Enrique.
Thank you.
Thank you.
Thanks, everyone.